Good evening, doctors, and welcome to our part 3 of COVID-19 topic of Wellness Center Experience. This is the third one that we are doing in the series. There will be one more after a few days. I'll just mute everybody of you for a moment so that there is no disturbance. First thing that I would like to offer is our heartfelt condolences to families of the healthcare workers of our organization who succumbed to COVID-19, and our hearts go out to their relatives and friends. And we pray to the God that their families withstand to this great loss of their family member. Also, there are many doctors and healthcare workers who are taking treatment currently from after contracting COVID-19, and some of them are discharged, some of them are at home recovering from this coronavirus infection. So we wish speedy recovery for all of them. The special feature of this uh, presentation is we are going to have a live quiz, and you may take this quiz from the same device that you're listening to. The only thing that you have to do is just click on this link which has been posted on the WhatsApp group to vote whenever you are asked for. And there are no correct or incorrect answers. We are only going to look after the inclination and clinical judgment of doctors in the current scenario. So we'll just have first one sample size sample of the quiz. So if you want to vote, please click on that link and see the results yourself on the presentation that you are currently watching on your device. So you can vote. You will get 10 seconds for voting on the quiz question, and after 10 seconds we will move on with the next question. So if you are able to vote using the link posted on the WhatsApp group, please vote. So these are some of the responses which you'll be able to see on the question given. So this is our wellness center, my wellness center, which is currently recording maximum walk-in cases. These are all walk-in cases that we screened in our wellness center. And you can see after, especially after August, there has been a consistent rise in the cases. So the cases are not decreasing. In fact, they are rapidly increasing. We are at 126 as of 30th September 2020. The worrying feature of this statistic is the number of hypoxic patients who come in their cars, or they are brought in critical state with less than 90% saturation. So far we had around 9 such patients coming to our wellness center. So this tells you a worrying picture of this pandemic. I've just taken out this graph of where on what day they actually present. So you can see on Tuesday we have maximum diagnosis, and as the week progresses, the positivity goes down, or the people coming with positive reports are less. This may have implications for uh, planning your wellness center manpower, on devising strategies to mitigate the exposure to the staff. So you have to be careful on, say, Tuesday or Thursday, as in my wellness center. The statistics may be different from each wellness center. We have started home isolation video consultation for our patient, because the number of patients that we are having in home isolation is also increasing. So we every day, our wellness center doctors, between 7 to 8 p.m., we have given a dedicated WhatsApp number, and also we use the same platform of Zoom sometimes to interact with these patients. And this is very much welcomed by the patients, and we also feel that this is a very important service, because these people keep texting us or calling us throughout the day, which keeps all your team members busy. So what we have decided is fix a time and give home video consultation to all these patients. So these are some of the pictures from uh, video consultations that we have done so far. Dr. Rangari, you can see today we have Dr. Patwardhan, Dr. Sarita, our in charge, also joins this WhatsApp consultation, and also Dr. Murli Mohan, who is one of the doctor from our team. So what protocol that my wellness center follows for any suspect or a fever patient is, we send a lab first of the basic hemogram, LFTs, RFTs. If the patient is not ready for immediate COVID test, we keep it for the next time, because we don't force these patients to, if they are not willing. And we see for signals in these initial lab on the next day. And if the signals are very strong, and we then recounsel the patient to go for the RT-PCR. We don't ask the patient to undergo antigen test, because the accuracy of the antigen test may be less. So what we do is we give a RT-PCR. If in a first go they agree, then we do it on the first day itself. And after the RT-PCR report, either a positive or a negative report, we do counseling in both the patients. And we also do risk assessment, because everybody knows RT-PCR, first RT-PCR may be negative. So depending on the scenario of positivity or negativity, we counsel and we do risk assessment. And from that, we send a patient either for home isolation if we are very confident that this patient can go for home isolation as per the government guidelines. But if we see the risk is very high, we see problems in home isolation, depending on the signals that we receive on the first lab, we may directly send the patient for hospitalization, even if the patient is willing for home isolation. So this is the simple protocol that we follow. Sometimes if the diagnosis is something different, we change our protocol. So this is a basic protocol that each and every doctor of our wellness center tries to follow. So what do we see in blood abnormalities of these patients? So what is our data of wellness center number 5? And this is one poster from one of the WhatsApp posts that I have copied here, that one of the company is trying to give this simplified uh, abnormalities of CBC to identify COVID and influenza, but our experience is very different. So we don't see all what is given here. We have seen a normal WBC count in 35 patients out of 91 who were diagnosed positive. This slide was made when the count was 91. So 91 patient had a normal WBC count. So it is not always that WBC count goes low. Lymphopenia was observed in a very, say, hardly 10% patients. Same was case with the neutrophilia. And in normal WBC count patients, 2 patients have died. Very few patients have thrombocytopenia. One patient who had a thrombocytopenia and tested positive, one died. So this is our experience. So WBC abnormalities or hemogram abnormalities may not always tell you what is given in such type of charts. It is always a clinical suspicion, which is more important, and your history taking. So we will come with the first case, and after this first case is described, we'll go for the voting, where you'll get 10 seconds for voting. So this is a case one. Is a 74-year-old male with no comorbidities. Had fever, sore throat, and body ache of 3 to 5 days duration. He had a normal examination, that is auscultation that we do, and oxygen saturation. Chest X-ray was normal. The dengue NS1 was negative because his platelet had come down to 1 lakh. His C-reactive protein is not elevated, it is less than 5, it's 2.3. You will see here there is a decrease in WBC count. Platelets have reduced, but neutrophils and lymphocytes are normal. So the question that we have is whether this patient has a COVID or does he have something else. Dengue he has tested negative. So what is your inclination? So depending on the details provided to you, please vote on the link given. What do you suspect? You have 10 seconds to answer. Is he a strong suspect or he is an unlikely COVID-19 or something else? I will wait for 10 seconds. There is no correct or incorrect answer. It is just testing your clinical judgment, because based on only on few details you are forming your inclination, and that is how you will make the case investigate further. So this quiz only is testing your inclination. So if the voting stops now, so right now we have 63 63 doctors, 67% of doctors, 70% now still consider COVID as a strong suspect, and very few, 10% think that it is unlikely COVID, and 20% think that we are not very sure what it is. So we'll see what happened in this patient. So this patient, we tested again as per protocol for RT-PCR. He turned out to be negative, but we counseled the patient to be isolated in home, considering that first test may be negative. We gave only oseltamivir and paracetamol, and on the day 3 all his symptoms disappeared. So what it is? Less platelet, leukopenia, but negative RT-PCR. So we wanted to know what is the diagnosis. So after 1 month, I asked the patient to undergo COVID antibody test, and those COVID antibodies came negative. So the clinical conclusion in this patient was that episode of sore throat, fever, and body ache was, say, we can say definitely it is not a COVID now retrospectively, because even the antibodies have come negative. There could be a small, very small possibility that still he has not developed antibodies. The RT-PCR could have been false negative, but largely this patient is COVID negative. So I wanted to highlight the abnormalities of blood count, that leukopenia, thrombocytopenia in a NS1 negative patient not necessarily is COVID. It can be our simple influenza, it could be other viral fevers. So, but that is how we investigate and retrospectively diagnose such scenario that this is not a COVID. So we move to the next case 2. Now the case 2 is of that of a female which is young, 19-year-old. She had high grade fever, body ache, no cough or breathlessness. Her blood count, you can see that she has the first blood count showed WBC of 4,300. So lower side platelets were reduced 1,400,000. We repeated her CBC again on day 3, and we also asked for RT-PCR COVID-19. So we can see there is a decrease in the platelet count. It has gone down to 29. There is a rapid fall. CRP is very high, 21, but there is a lymphocytosis. Neutrophils are not high. So what do you think this has? It's time for taking quiz. Please uh, click on the link given and vote. So I'm sorry, this is little mistype. This is case 2. So what is your clinical diagnosis? Please vote. You can see your own responses. If you have completed the voting and came back to the presentation, you can see the live voting going on. Another 5 seconds, I'll keep it. So there is a roughly equal dengue, strong suspect for COVID, still roughly the same amount, but little less, say it is unlikely COVID-19. So let's see what this case came out to be. We will stop the voting. So her platelet count further dropped to 22,000, and we tested her for NS1 as we do for all thrombocytopenia patient, and NS1 antigen came positive. And you can see now there is a further changes in her neutrophils have gone down, her lymphocyte have further increased, and her platelets came down to 22,000. So she was advised admission because it was approaching 20,000, the threshold for admission and spontaneous bleeding. Being young, that time admission, getting a bed was a big problem. The parents could not make a decision of admission. So she came RT-PCR negative. She came NS1 antigen positive, but she recovered without admission. So we went on doing platelets count. The next count started climbing up. So 22,000 was her nadir, the lowest count that we had. So as per one of the article on hematology abnormalities of COVID, severe thrombocytopenia less than 50,000 is very rare in COVID. It is only seen in 5% of the COVID cases in one of the series. So this is one of the message that this case gives, that if you see a profound thrombocytopenia, then you should think more for the dengue and less for COVID. But there is a catch here. There could be dual infection, COVID patient getting dengue. This is a well-known in literature. We have seen such cases. So you must test if you see a lot of thrombocytopenia, test for COVID and test for dengue also. And if the typical thrombocytopenia in COVID is very mild, it usually does not fall below 1 lakh and it quickly recovers. So in dengue, you see profound thrombocytopenia. So you can use these differentiating features. So we move to the next case, number 3 actually. So this is a number 3 case of fever. 2 days fever with joint pains. So with joint, shoulder, elbow, wrist, ankle. and knee in a 38-year-old female. They were bilaterally symmetrical. LFTs, RFTs, urine routine, CRP, all were normal. And you can see here, there is a near increase, little bit increase in the WBC count, very mild, 10,200. There is a neutrophilia. There is a lymphopenia. The platelets are normal at 3 lakh. So what do you think this case 3 fever has? Please make your clinical inclination. We are going to vote. So what is your clinical diagnosis of this case? So half. Now it's more going in favor of chikungunya. Very less people are suspecting COVID. The percentage is further going down. More people feel this is chikungunya. Again, COVID suspects are moving up. So you can see the live voting. But majority of the doctors feel that this is chikungunya. So let's see. Some say there's none of the above. Okay. So we'll see what this case turn out to be. Some still are voting. Another 2 seconds. I will wait. So none of the above, but majority are going for chikungunya. So number case 3. So we again recap. So it is a presentation of fever with a joint pains with a normal CRP and neutrophilia with lymphopenia. So what it turned out to be? She came RT-PCR positive. IgM chikungunya. I was also thinking of chikungunya as one of the strongest differential, but she came IgM negative. She came dengue negative because we normally send all tropical labs in some patient. She was also detected to have new diabetes, and she's currently in home isolation. And she's almost, I think today she has finished home isolation. Whole of her family, 4 members, all came positive. All were under our wellness center, home isolation care, and everybody did exceedingly well. Nobody required a hospitalization till late. So this was a presentation of joint pain, fever with COVID. So this is a little bit of googly for us. So think about these possibilities. But thinking about chikungunya is also a good differential diagnosis, and still it should be at the top of the diagnosis in such cases, even though this case has come COVID positive. So this is a one article that I have. I want to mention that a very important test is a CRP, and the CRP levels correlate with the diameter of lung lesion. Higher the CRP, without doing a CT scan, you can say that this patient already, his CORAD score may be higher. And they have categorized into 3: mild CRP, that is up to 40. Below 40 mild cases, usually the CORAD score is less. Between 50, 60, it's a moderate COVID. The CORAD score correlates with that. And anybody who's more than 60 CRP, these patients are usually severe COVID. And at initial CRP level, this is a good differentiation. Now, case number 4. This is a very interesting case. We managed this case fully on telemedicine, and I'm happy about the outcome. So it's a case 4. Is a 73-year-old male patient with a 3 days of fever, chills, cough, weakness. Is also mild asthmatic, sometimes uses inhaler, but his saturation was normal. On auscultation, uh, absolutely normal. This was his actually a second CBC score. First was WBC was normal, but now this is a second one showing leukopenia. The differential cell count, surprisingly, it is normal. There is a mild reduction in platelet count 1,32,000, just below 150. But their transaminitis is quite visible. So SGPT, SGOT is quite more than 100. Less, little bit of albumin, less. His high sensitive CRP is little bit high, not very high. His saturation was normal. So what do you think about this case? It's time for voting, and keep your links ready. I will like to show this picture also. On fourth or fifth day, he developed this rash. I do not know whether you can appreciate, but he also developed this arthritis of small joints and a rash on his left and right foot, a very faint maculopapular rash. So what do you think this patient has? A patient with arthritis, a rash, raised SGPT, SGOT, high-grade fever with chills, elderly gentleman, saturation normal. So there is an equal division between COVID and chikungunya. So few people are changing their mind, but still it's half. Another 2-3 seconds I will give. So we'll stop for the voting and we'll see how this patient did. So this patient was RT-PCR negative. Fever subsided after 2 weeks. His arthritis remained. He had intermittent fever. And his rash also disappeared. His saturation remained stable. They were very reluctant to get admitted, and at one point of time when they were ready for admission, this patient couldn't get a bed. The even old wife somehow managed this patient at home. We saw this patient 1 month later. We did his COVID antibodies. His COVID antibodies have come negative. And this patient, we can say that this could be a chikungunya because they did not do chikungunya antibodies even after repeated request. But I think this was more in favor of chikungunya because he had this typical transaminitis and a very different picture which you don't see much in COVID. And here he was COVID antibody negative. So we had this a fever patient. We clinically concluded this could be chikungunya. He still has arthritis, which is typically seen even after 1 month. So this can be chikungunya. So we have 10 minutes left. We can rejoin on the same link if sometime in case we break down. Now this is a very interesting case that I would like all of you to pay attention. I'll give more time for viewing. This was an elderly, this was a young male who was detected with a SpO2 of 85% on 3 different oximeters, confirmed similar reading. So the machine fault was not there, and he was detected on a routine office screening. He did not have any symptom even that at that time. On 8th September, this was his reading. He was totally asymptomatic. He underwent HRCT lung scan which was normal. His RT-PCR was negative.